First things first. Good afternoon. Today's March 26, 2025, and it is 2:34 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Ad Hoc Appointments Committee. As a reminder, some of our committee members may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have legally compliant meeting at all times. We now receive public communication for the Ad Hoc Appointments Committee meeting. Is there any public communication? No. Thank you. We'll now proceed to committee agenda. Agenda item 1 is approve the minutes of the Ad Hoc Appointments Committee March 17, 2025 meeting. Do I have a motion? Cynthia, do I have a second? Thank you. All in favor? Nays? Thank you. The motion moves. I would like to move to agenda item 2 now, and that is to discuss and take appropriate action on the appointment of 2 members of the governing board of Sendero Health Plans, and I'll be presenting this item. I'd like to now go into closed session. So I announce that the committee is convening in closed session to discuss agenda item 2 under Texas Government Code 551.074, personal matters. It is still March 26, 2025. It's now 2:35 p.m. Ready? Thank you. We're coming into open session. It's March 26, 2025. It is 3:45. At this time, I'd like to take a vote on the candidates proposed, and we'll vote first on Libby Doggett. Oh, we're missing Minnie Jones. Okay. Where'd he go?
Can we just read the motion like the way it's written here?
Sure.
I can move it if you want.
And then we'll just repeat it. How's that?
Yeah,
Repeat it for one. Okay.
yeah. I'll just read it. When you're ready.
I guess the idea of taking a vote beforehand was imagine someone says no, no, no. Just that we actually. Okay. Can I have a motion to?
I'll move. I move that the committee recommend that the board appoint Jonathan Morgan and Dr. Libby Doggett to the governing board of Sendero Health Plans.
Have a second? Second by Dr. Brinson. All in favor?
Aye.
Aye. All opposed? Abstain? Oh, no,
Yeah.
sorry.
We're not
Okay,
voting.
well, therefore, I'm looking at trying to be polite. Okay, the motion passes. Thank you. Okay, thank you. Okay. Agenda item 3. Discuss and take appropriate action to expand the number of directors on the Sendero Board of Directors. I had discussion with Sharon and with Mr. Garza about this issue, and the feeling was that expanding to 9 in the context of the talent that's available to us would be a good idea. Does anybody have any suggestions going around the corner? Manager May? Manager Jones?
I think I'm expressed by.
Okay, all right, thank you. Manager Kitchen?
I think it's a good idea. It will provide more opportunity for the Sendero board to bring in some additional talent to help them, particularly in how they respond to, relate to, and work with the public and the community.
Thank you. Manager Brinson?
I think it's a good idea, and I think we will all learn, perhaps, hopefully, from the talent that they're able to bring on.
Thank you. Manager Valadez?
And I also look at this as an opportunity. I also see this as an opportunity for Sendero to grow and also look at the demographics of makeup of their boards so that it could be also representative of their membership and the population that we serve.
Thank you very much. At this time, I'm ready to accept a motion.
I move that the committee recommend that the board adopt a resolution allowing Sendero board to expand to the number of directors on the Sendero board of the number, let me go back.
sorry, adopt a resolution allowing the Sendero Board to expand the number of directors on the Sendero Board of Directors to as many as 9.
Do I have a second? Second, Dr. Brinson. All in favor? Aye.
Aye.
All opposed? Manager May? Manager
No,
Jones?
I meant-
Abstain? Abstain or?
Abstain.
Okay, thank you. The motion passes. Thank you. At this time, I'd like to confirm the next regular ad hoc appointment committee meeting date, time, and location. We do not currently have a scheduled Central Health ad hoc appointments committee meeting. When a need for a meeting arises, we will work with committee members and other managers to choose a date and time that works with everyone's schedule. I would like to ask staff to reach out to Ms. Davos and let her know. At this time, I'm ready to accept the motion for adjournment. And second by Manager May. All in favor?
Aye.
Aye. It's done.
Okay, everybody, we'll be starting budget and finance at 4, so we've got a little time.
Okay. Everyone knows me a treat. We finished it.
Yes, you did. You finished ahead of time. You had to finish ahead of time.
Perhaps stash them away for a while. I know. Oh, olvídate. Oh, I know. Well, I tell you that conversation. I had a conversation with one of the surgeons up at Dell.
Let's see.
Okay, wonderful. Well, good afternoon, everyone. Today is March 26, 2025, and it is 4:02 p.m. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. Do we have anyone participating? No? Okay, thank you. I would like to announce that in order to make it more accessible to community members, we will hold public communication for the Budget and Finance Committee and the Board of Managers at a time certain at 5:30 p.m. unless someone would like to speak now. Do we have anyone signed up?
We have one person signed up to speak at 4 p.m.
Okay, perfect. So, can you please read her the script?
Yes. So it's Sharon Alvis, President and CEO of Sendero Health Plans, and I will now read the public communication. When called upon to speak, please introduce yourself by name before beginning your comments. Also, if your comments will focus on a specific item or issue on the agenda, please indicate the full item number after your introduction. Each speaker will be limited to 3 minutes. Staff will be timing each speaker and will announce when a speaker has reached their time limit. To ensure the efficiency of the meeting, once we have let speakers know they've reached their limit, we will allow 30 more seconds to wrap up their comments before they are muted. Due to the restrictions of the Open Meetings Act, the board may be restricted in discussing any items that are not listed on the agenda for this meeting. The board may choose to set aside any new issues for discussion of a future meeting. Okay, Ms. Alvis, you have 3 minutes. Thank you so much.
Thank you.
Thank you. I just wanted to bring to the attention of this board that as the screen displays, Central Health and Sendero were awarded this morning the Transformational Impact Award by CAN. And I was there along with Kit Abney Spels, and Rudy Ibarra from my team, and we received this award and on behalf of Central Health. And so here is the reward that we received, and it was a great honor to do that, and we were very proud to be able to received this. There were 5 recipients in the community, and it's about the the Central Health and the CHAP expansion program and how well that has worked. So that's what the award was about, and we are delighted to have received it on behalf of Central Health and Sendero. So thank you very much.
Congratulations to you and the team, and to everyone involved. Thank you. Any further public comments?
No, this concludes public communication. Thank you.
Do we have anything at 5:30 today?
We do not.
Okay, so we will not need to break. Okay. So, members and community, before we proceed, just a public health announcement. We encourage everyone to get vaccinated. Vaccines save lives. So I don't know how many times we need to attest it. We need to remind everyone. It's unfortunate we have an outbreak for measles, and unfortunately a kid was lost, and his life could have been prevented if his parents elected to vaccinate him. So I encourage everyone to remind your friends, your neighbors, anyone to get the vaccines, especially the ones that are recommended by CDC and others, experts. And also there's a cancer preventative vaccine, HPV vaccine, that is recommended for both boys and girls around 9 to 11 years old. You can take it up to until you're 45 years old, but if you take it under the age of 15, you only need to take 2 shots rather than 3, and can protect you against 6 or more cancers related to the HPV virus. So that is really the public health announcement. I hope we all can follow through, and we can save lives. Now, that concludes my comments there. Now we'll proceed to our committee agenda. Committee agenda number 1, approve the minutes of the February 26th and March 12th, 2025 Budget and Finance Committee meeting. I move that the committee approve the minutes of the February 26th and March 12th, 2025 Budget and Finance Committee meetings. Do I have a second? Chair Kitchen seconds. Any discussions? All in favor? Motion moves. Thanks. Agenda item number 2, receive a report of historically underutilized business hub spending performance for fiscal year 2024. Members, there will be no presentation on this item. Materials are in the backup, and staff are available to answer any questions offline. Thank you. Then there's no motion for that. Moving on to agenda item number 3, receive the February 2025 financial statements for community care health centers. Joy Sloan and Christy Pellegrini will be presenting. And we have, welcome. Thank you.
And Christy will be joining.
Okay. Thank you for being here. Thank you.
Good afternoon. Thank you for having us here today. So I know we presented last month as well. There's not been significant changes in our financial position since our last presentation, so I'll walk through a couple of high point things. There were questions last time regarding the pharmacy program, so we did ask Christy Pellegrini, our VP of Pharmacy, to join today to walk through a little bit more of the nuances around that particular program as well. Next slide, please. So we do continue to have operating losses on a monthly basis. And as discussed previously, the decrease in the pharmacy margin has definitely impacted our operations this year. We would have expected at this point in time to have produced about another $2 million in revenue off of that revenue that we did generate. And because the margins are tighter, we did not do that. So that really impacts our ability to offset some of the lost revenue around patient services revenue generation. And we are seeing lower budgeted encounters, and we're continuing to feel the Medicaid impact. So currently, we're at about a $5.2 million loss. Next slide, please. When we look at the 340B program, I'll kind of introduce it and then turn it over to Christy to walk through a couple of slides. But historically, we saw our cost of our drugs to be about 55 to 60% of our revenue. And we've steadily seen that shrink as we've seen the impacts from the regulatory pieces related to the pharmacy 340B program. So where we would have generated about $12.9 million on $32 million worth of revenue, we're generating about $10.3 million. And so that higher margin, that higher pharmacy cost, then doesn't bring as much revenue into the program to offset other operating costs and other operating variances from budget. And so when we look this year at lower encounters than budgeted, payer mix that's not optimal to what we had planned, and we couple that with an increased impact on the margin for the pharmacy program, that really puts a lot of pressure on operations. And expenses are running pretty much at budget. So we're not seeing the savings related to the expense side. Next slide, please. And Christy.
May I ask one question?
Yes.
I'm sorry. I'm sorry, manager. My apologies. I just was curious about the $5 million loss. Is that in a fiscal year or just 2 months?
That's fiscal year.
Okay, thank you.
Next slide, please, and then I will turn it over to Christy Pellegrini.
Hello, can everyone hear me?
Yes.
All right, I'm hailing from Houston this afternoon. Thank you for allowing me to join. I'm Christy Pellegrini, Vice President of Pharmacy Services for Community Care. So just wanted to give everyone an overview of the 340B program because it is such an important component of our budget, as Joy has laid out for us. So you may or may not know about the 340B program. Essentially, it is a federal program that allows safety net providers to stretch scarce federal resources as far as possible. And it allows those safety net providers to reach more patients and provide more comprehensive services to the communities that they serve. And on average, the discount that covered entities get from the 340B program as compared to a retail price is about 33%. And it's important to note that community care and the enterprise generates savings through the 340B program in the form of cost avoidance, meaning that, if something was $3 million, we would then have spent $2 million instead if we had an average 33% discount. The other way that we generate savings is through margin, which is net revenue. So those are actual dollars coming in minus the costs, the drug costs. And we use those funds to fund programs that are within our scope at community care. And it's also important to note that federally qualified health centers like community care are required to reinvest any 340B program revenue back into our patient services that are in scope. And it allows us to provide what we would consider community benefit services. So these would be discounts on medications and that are provided at no or low cost, home delivery of medications at no cost, and provision of clinical services that operate on no or low reimbursement, vaccination pop-up clinics, patient transportation, and provision of patient education. So those are all gaps in care that we're able to fill using 340B program savings. And I thought an important number to share with the board was that if we look at the entire enterprise 340B purchases, then that number is $65 million. And again, if we consider that the average discount on 340B program is 33%, if the 340B program just completely went away and we didn't have access to it anymore, the retail value of those purchases would be 99 million, so almost $100 million. And therefore, the total savings to the enterprise in the form of cost avoidance or net revenue is $34 million. Next slide. I just wanted to touch on what Joy was speaking to with the shrinking margins. And there are some really main drivers for the shrinking margins. The biggest one is manufacturer restrictions. The 340B program is not a taxpayer-funded program. It is a requirement of manufacturers when they participate in Medicaid and Medicare that they offer covered entities, hospitals and clinics that are considered covered entities, these 340B prices. And as you might imagine, the manufacturers don't like that. And so they have found ways to restrict our access, hospitals' access, clinics' access, and by proxy, our patients' access to their medications. So since 2020, about 30 manufacturers have imposed restrictions on our ability to purchase drugs at 340B prices at our contract pharmacies. And in our county, that is largely the HEB pharmacies for which we service our MAP and sliding fee patients. And community care separately also has some arrangements, contract pharmacy arrangements with other chains. And the restrictions have changed over the years, growing in their restrictive nature. And again, the enterprise uses those contract pharmacies to increase medication access points. And so when the manufacturers apply restrictions, it becomes more difficult for us to provide those access points. The way that we've mitigated these restrictions over the last 4 or 5 years is that we have used drug utilization management strategies, including looking at our own formularies and preferred drugs to manufacturers that are friendly to covered entities. But again, the manufacturers are increasing their restrictions, which is making it more and more difficult to navigate. And the one good thing is that our in-house pharmacies have not been impacted by these manufacturer restrictions. There are some other things that are impacting our contract pharmacies and our in-house pharmacies. And one is that the patient assistance programs have changed over the years. At one point, excuse me, allergies are terrible and my voice is, it's hard to talk, sorry. So over the years, the manufacturers have changed their patient assistance programs from a model where they give the patients a card to use at any retail pharmacy. And in doing so, they give the patients more immediate access. And it also afforded community care an opportunity to generate that net revenue that I was talking about. And they've changed those programs from that card to shipping the medications to the patients directly. And when that happened, we lost that ability to generate that net revenue. It's important to note that the enterprise continues to benefit from those manufacturer patient assistance programs through cost avoidance. So these are medications that we would have purchased. We were able to get them through the manufacturer program for free. So we're still receiving the benefit that way. And the final way that our margins are shrinking is just overall increased drug prices. And the statistic that I wanted to share is that since 2009, the retail price of brand name prescription drugs has more than doubled in inflation-adjusted dollars. And so these overall increases in drug costs are causing the margins to shrink, as Joy was noting. I also wanted to point out that there are some things on the horizon. The Inflation Reduction Act will cause some downstream effects on reimbursement. But one impact that it's had today is that there are something called maximum fair prices. Those are the negotiated prices for Medicare that you may have heard about. And those maximum fair prices have actually driven up the 340B price of medications. And these are blockbuster drugs that would otherwise have generated a lot of margin for community care and the enterprise. And so they're very impactful. There's a reason why these drugs were chosen for the Medicare negotiation, because they're extremely popular and they are effective. They're also extremely expensive. So finally, I just wanted to make sure that I left with a little ray of light in that community care and central health are working, we continue to work on options and investments, mitigation strategies to offset some of these margin losses. So just know that, you know, your leaders are looking at ways to offset the losses and find other ways to generate both the net revenue and the cost savings for the enterprise.
Thank you.
Thank you, Christy. Next slide, please. So we continue to face many challenges this year. The balance sheet hasn't changed significantly from last month. We did see cash drop just slightly. We continue to have accounts receivable sitting fairly high, and most of our liabilities still continues to be either in pharmacy drug costs or accrued payroll and benefits and PTO liability. Next slide, please. And we do have a couple of things to talk about with open provider positions and encounters. I will turn that over to Nick.
Great, thank you, Joy. So last month, I think we had mentioned that the three drivers that generally have posed challenges for us are the Medicaid enrollment, the 340B restrictions, and provider vacancies. The provider vacancies bit is worth a little bit more detail. Every health system is going through challenges related to provider hiring, given the competition, particularly in primary care. Ours are focused in very specific locations. The first is our convenient care model. It is one that we used to actually contract with a third party to provide those services. And a number of years ago, we moved to internalize that to try and integrate more deeply into the primary care workflow. We have found challenges sustaining that over the last couple of years. And this is for a number of reasons, not worth getting into in too much detail here, but it has resulted in higher turnover by far than any other service line. And as a result, we're making some modifications for how we approach convenient care in general. Another aspect of our model that has proved challenging is that we took a bit of a risk a number of years ago where we decided to hire more inexperienced advanced practice providers, believing that our model was so strong and our infrastructure so well developed that we could train them on the job. It's turned out that we don't have strong enough infrastructure to sustain that. And so over the last couple of years in particular, we've seen increased turnover amongst those new graduates, advanced practice providers. And so for the time being, while we do believe that pipeline is an important investment in the long term, we don't feel like we can sustain it in the short term. So we've shifted our philosophy around hiring to target more experienced advanced practice providers for the short term while we build the infrastructure to sustain both that training pathway as well as a different convenient care model. Lastly, there have been a number of transitions, not substantially above normal, where providers have moved out of state, frankly, largely for family reasons. that would be part and parcel of what we would expect for any healthcare entity. So that, I hope, gives a little bit more structure, that when we talk about some of the vacancies we've been working around, it's really been focused in two discrete areas, and ones that we have shifted our strategy around in order to sustain the transition in the short term. I believe, well, let me just mention that at the bottom in smaller type, there are a number of additional programmatic elements that we've included. First is introduction of incentive pay structures. That is a feature that in our hiring has been asked on for years and years and years. We think it actually aligns with some of our objectives to move into a more of a value-based payment structure. So that's in development. We've also developing strategy within HR for resources for provider retention and more in-depth relationships, and then targeted recruitment, as I mentioned, for experienced advanced practice providers. So next slide.
I think that's the last slide.
Oh, great, thank you. So we'll take any questions if any have any.
Thank you. So I am going to open the floor and then I'll ask my questions. So Chair Kitchen asked first.
Just quickly, could you go over the convenient care staffing model again? So that's the model that you're moving away from because it's not been effective?
Forgive me, I didn't mean to suggest that convenient care itself we are moving away from. It is the internally hired. It is a very specific type of training that providers go through to do what often is called urgent care. We had attempted to fill those positions with primary care specialists, but that high throughput, the high volume that is expected in urgent care settings where you're really addressing immediate needs and then feeding into a primary care long-term relationship, has proved a little bit more challenging given a number of factors, not just the training of the providers, but the ability to take in those providers immediately into a primary care home. So we will continue with convenient care, the same FTE, the same locations. In fact, it's an area that we need to expand on from a strategic standpoint. We're just using a different staffing model to it, where we'll have providers who have much deeper training in the convenient care or urgent care space.
Okay, so the staffing model is
Yes.
different, and that's what, the older staffing model is what has contributed to the lower number of encounters. Did I hear that right?
Well, the lower number of counters is largely due to the turnover because what we
Okay.
ended up seeing is using the present staffing model, we saw a lot more burnout among staff who
Okay.
had been trained to do primary care. And so it's that turnover that leads to disruption in access. By working with a third-party vendor, we expect to have sustained engagement of providers as part of the contract structure.
Thank you.
Thank you. Manager Martin.
What is, by third-party vendor, what do you mean?
It is an external staffing agency, not a staffing agency, a provider group that provides staffing for emergency rooms, urgent cares, et cetera.
So yes, get him care. So have you, I mean, not to go into detail, but have you, and I'm a primary care doctor, have you approached efficient local clinics to subcontract out to see these patients, for example, expand the hours in a way that would allow for people to be seen that way? But to go to ongoing clinics, for example.
So we have done that all internally. We have not subcontracted with other clinic systems, and part of that has to do with the requirements of FQHCs and the regulatory requirements and such. But largely, that move to creating greater access from hours of the day or locations, et cetera, we've focused on developing internally.
But say, like, assuming making a clinic, a private clinic into an FQHC clinic, just assuming that control, is that something that could be done legally with FQHC?
We'd have to talk through that, and you're saying not through an acquisition, but just through a contract?
Through a contract.
I'm not sure I can answer all the
Okay,
legal
I'm just
ramifications of that, but
curious, so,
fair.
okay, thank you.
Thank
Well.
you. Any further questions?
I have a question along the lines.
Manager, your speaker.
I have a question along the lines that have already been asked. But more specifically, if this is available, what percentage of your service provider, of your service needs, or this, no, let me go back. What percentage of the services that you're providing, medical services that you're providing, are done by third-party providers?
We have contracts, so a minority. We have contracts in a number of spaces through our relationship with the medical school, through our relationship with Ascension, but it is a small fraction. Well, let me add that through our graduate medical education as well, many of the residents are employed elsewhere, but we contract for their services as well. But it does represent quite a minority. I don't have the exact number for you.
That's good enough, thank you.
Thank you. So I have a question. You mentioned there will be a 5.2 deficit, 5.2 million. What is in your reserves? How much do you have in your reserves right now?
So we don't have reserves in the sense that they're a separate fund of money that's off to the side. What we have is board reserves of 12 million. That's included in the cash on the balance sheet.
Okay, and we don't know what will happen in terms of 340B and that what? Okay, so it's good to know in terms of, you said about roughly 12 that you'll be able to tap in. Now, going into the provider turnover, I think what personally matters to, I believe, all of us is the patient care. So to me, it's deeply concerning. It's troubling in terms of the care they're receiving and the wait times for our patients who tend to have multiple chronic illnesses. So as you're navigating this hiring, filling it, what are you doing intermediately to help alleviate the pain and the burden in our patients right now? So if you can elaborate on that.
So we hold those same concerns. Access and delays in care are some of the primary drivers of disparities in health outcomes. And this is core to what our strategy is and our mission. Fortunately, we have been over the last number of years both increasing our access to care year over year. And I believe there was a 7% increase in the total number of patients we were able to see this year compared to 2024 compared to 2023. Additionally, we take very seriously the quality of care we offer, and year over year, we're also seeing improvements on our quality performance, even getting recognition from the Health Resources and Services Administration. That doesn't give the full access, and part of the excitement that we hold this year is through greater partnership with Central Health. How do we not only open new sites like the Del Valley site, the Hornsby Bend site, et cetera, but how do we expand in different dimensions? We have opened a new service line in the past 12 months that is purely dedicated to telehealth services. So even if folks can't get an in-person visit, or even if they prefer a telehealth visit, we now have a service line dedicated to just that. That is expanding as we speak. But this is part of the objective over the next 3, 5, 10 years is how are we going to build the access points that includes not only sustainment of a workforce that is reliable and able to perform at the highest function, but that meets the demand, supply and demand mismatch is closed.
That's great. My last question, what's the wait time for patients to get an appointment to see a primary care physician?
So to get into for the convenient care, you can just walk in. At all of our sites, there are walk-in services in general. For a new patient, do you have those exact numbers? Forgive me, I'll have to get back what the exact numbers are, but there are new patient and then there are established patients to get in with their providers, but I don't have those numbers in front of me, my apologies, but I can get them back to the board.
Thank you, that will be helpful. Thank you so much. Any further questions before we move on? Yes, ma'am.
I want to congratulate you all. I know that you have increased number of patients that are participating in this great service that y'all have been award-winning service from HRSA and everybody else. with lesser number of providers. And so I think that's something that our community needs to take into consideration, that your commitment to quality, the highest quality service, and the commitment to providing for their needs is always going to be first and foremost in your priority list. And I just want to thank you all for
I
that.
appreciate that. If I can add one additional note, and that is that we actually are growing our provider numbers year over year because we are expanding services year over year. And so while we look at vacancies, a lot of those vacancies are actually attributed to new sites that have either been slow to open, but we carried on our budget for most of the year, or are just in the process of what it takes to open up new clinics. So we do have very specific holes in our provider line, but those are ever growing. The actual workforce is actually growing year over year. So thank you.
Well, thank you all so much. Manager Jones?
Just one quick question. In light of what's happening in Washington, I know you don't know all the houses, have you gotten feedback or hearing from your federal or state contractors about HRSA itself and its ability to be able to do what it has historically done? Or is there going to be a change in that process as well? Have you heard anything?
There have been so very important question. Thank you. There is much discussion being had behind closed doors that I'm not privy to what the content will be. I certainly expect that we will be asked to report our data in different ways. Fortunately, federally qualified health centers, community health centers in general, the HRSA 330 program has received bipartisan support. We are a lifeline for rural health as well as urban health. And so I am fortunate that I feel optimistic that we will be able to sustain our funding. We just had additional funding extended with the most recent continuing resolution. But I don't have any details. But I do know that there is anxiety about what the future holds. But I feel that we are actually in a better position than many other public services.
And you haven't heard anything about slashing at the headquarters type of things that is going on in like CDC and some of the other areas of health?
There has been discussion about how scope of service may be, or scope of project may be adjusted. And I don't know the details, but one could conjecture based on some of the conversation at the federal level that, for instance, gender affirming care may be excluded from approved scope of project. Again, this is all conjecture at this point, but I suspect that that is under discussion.
Well, thank you all so much. Appreciate it. Thank you. Now we're moving on to agenda number 4. Receive the February 2025 financial statements for Central Health. Nikki Riley will be presenting.
Hi.
Hello.
Nikki Riley, Deputy CFO of Central Health. February financial statements, not a lot went on in February. In the highlights, you can see that our tax collections are good, on point with last year. We did make a debt payment this month on our debt issuances, and direct services are higher than last year. Everything's going really good, 13.4 million versus 4.9 million last year. I do want to take a minute to go over some of the detail services on page 8. Those are all of our direct services. Mostly salaries, of course, go into this. We are still in the process of just making sure we have everything in the right place. making sure that we are putting in, grouping things together as we should. So I'm talking to John all the time about how to improve that, how best to look at that so you get all the information that you need. And then I did want to point out, yes.
If I may, for slide 8, did you mention that's also salaries for the direct services included, or is it separate?
No, it's salaries.
This is just.
And it's mostly salaries.
This
because,
is mostly salaries?
Yeah, we're paying our providers. Those are our employees.
Do we know how many patients they're seeing?
Not in this financial packet, no. I can probably get that information.
Can we have that for next month?
Sure, yeah.
Thank you.
Okay. I will do that. I do want to point out one element on line 9. On page 9. It looks like one of the line items is over budget, physical, med and rehab. We actually are just coding some invoices incorrectly there. They should be in musculoskeletal. So I don't want anybody to worry that we're over budget. We're not. They're just booked in the wrong place. Those are the kinds of things we're continuing as we grow when we get these additional service lines to figure out and make sure that they're in the right place. So that is ongoing. The reporting process right now, the tools that we have are very onerous, and it takes us a while to do it, but we're getting better at it, and I hope that these can give you the information that you need. And I will get the number of patients, the number of encounters too, because I know I've seen those.
Thank you so much. So does that conclude
Yep,
your
that
presentation?
concludes my
Thank you.
presentation.
Any questions, Manager Valdez? Your speaker.
It's not really a question, it's just a comment for right now. If you look at the font, the size.
Yes.
I was just wondering if you're gonna be providing this with the sheets like this, can they turn them to the side so that they can be increased?
Yeah.
And we can see them better, read them better?
So mine is.
So it's this way.
yes.
And it's bigger than it is
Yeah.
this way and microscopic.
Yeah, I get
Thank
what
you.
you're
That's an
saying.
easy
I totally
fix.
agree.
That's, the only reason I'm saying that is because somebody didn't think about that when they did this, that's all.
I'll
Thank
work
you.
with Brianna. We'll be able to do that.
Thank
No
you.
problem.
Thank you. Any further questions, Chair?
This is on page 8. I just have a question related to the psychiatry services and the medical respite. So make sure I'm understanding it correctly. On the psychiatry, so it shows 5% of budget used year to date. And then there's no number under fiscal year 2024 year to date. So help me understand what that means. Does that mean that we budgeted a certain amount for psychiatry services and we're behind, or are we at the level we expected to be at this point in time, or what is the 5%?
John, he probably can tell you better.
Okay.
It would be hiring a psychiatrist at this point, because that would be the main cost that is in direct services.
Okay, I'm just wondering about the 5% versus the budget.
So the zero column, Manager Kitchen, is that what you're referring to?
Well, what I'm noting is that percentage of budget used is 5% for psychiatry.
That's a very recently established service line.
Okay,
We have one psychiatrist that has been hired and is practicing.
okay,
She's also in a leadership role, so only part of her time is clinical. She's trying to build the practice and hire additional psychiatrists. I think we've got additional coming online, 2 additional psychiatric positions that have been hired that are coming online. So in a lot of these direct service areas, these include newly established services that will ramp up as we get closer to the end of the year, based on when we're hiring and onboarding providers.
okay.
So
Go ahead.
if I can, following on that, with that information in terms of encounters, can you also provide us how many doctors are, and are they full-time? Are they seeing patients full-time, or what role they're in?
Physicians, APPs, staff, nurses, medical assistants, community health workers.
So if you can outline
social
that.
workers. We
Supplies,
have-
everything.
We have that's the entire service line related to each of those.
Okay, but there's no number under fiscal year 2024 year to date because it's a new service.
We did not, that service did not exist last
Right.
year, and why that's zero.
Right. Okay, all right, thank you. Might be helpful also, well, I think you just asked for this, the number of FTEs. Yeah, thank you. Okay,
I can do
thank you
that.
very much.
I'll just add it to this sheet.
Yeah, thank you.
Okay.
Manager Valdez, you had a question?
As a follow-up, also, clarification.
Your speak.
That specific, line, this is our central health, apologize, thank you. These are central health, specialty services that are being provided. We're not sending them to UT, they're not going to the medical school, they're not going somewhere else. This is central health?
These are services provided in a central health practice environment. It may include additional contracted services, so where we have physicians that are caring for patients in skilled nursing facilities, it will include the related skilled nursing facility cost or a surgery center cost. And some of those physicians are co-recruited physicians that we are contracted with UT for some of the provider time, so that would be included here as well.
Okay, I thank you, and that's one of the reasons I was asking specifically, because I know that UT does partner or does provide some services by their residents there at the Red River 15th Street, whatever it is, location, not 15th, Trinity, the Trinity location. And I was just wondering if we had a contract with them for that provision of services.
I'm not sure I'm following which location you're referring to.
The UT Medical School facility that's on Trinity
So this would
and
not
15th, it's
include-
not the medical school. I mean, it's not at Seton, it's at UT.
So the services that are provided at UT would not be included on this direct service page. These are services provided at Rosewood Zaragoza, at the Capitol Plaza Clinic, in East Austin. Yes, ma'am. So if it's provided in a UT practice, that would be on the network services page.
Are there any patients that are receiving services at those types of facilities?
At UT facilities?
Yes.
Yes, ma'am. So the musculoskeletal services that we've.
Page 9.
We've talked about, trying to think what else we have on here. There are some psychiatry services, gastroenterology services, quite a few different service areas.
Then that's something I would be interested in knowing, the difference between, what we're paying UT for them to see our patients on their site, at their site, as opposed to we seeing our patients at our sites. Thank you.
Okay, thank you all. There's no motion for this item. Moving to agenda item 5, receive and discuss the quarterly financials and operational updates for Sendera Health Plans. Managers, before we go into closed session?
Yeah, I think we got the announcement that Sharon did the announcement. We were gonna do the announcement right before we went into closed session.
Right before closed
Yeah,
session,
but
so do you want me to read it out? I thought you were gonna do it first and then I can go to closed session.
No, we've done the announcement.
did it.
The announcement was in citizen communications that Sharon did.
Oh, okay. Okay, perfect. Thank you for that clarification. So that takes us that we will be discussing items number 5, which I read, and item number 6, receive and discuss and take appropriate action on an overview of legislative and regulatory factors impacting Central Health's financial forecast. Managers, I am gonna announce that we are going to convening closed session to discuss agenda item 5 and 6. Under Texas Government Code 551.085, governing a board of certain provider of healthcare services, and Texas Government Code and/or 551.071, consultation with attorney. And it is March 26th, and it is 4:49 p.m. Okay, hello everyone. We are back from closed session. We discussed agenda items number 5 and 6. There were no motion necessary. for those two items. Now we're moving on to agenda item number 7, confirm the next Budget and Finance Committee meeting date, time, and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, April 23rd, 2025 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I'm ready to accept a motion for adjournment. Manager Brinson moves, seconds by Manager Valdez. Any discussions? All in favor? Motion passes. We're adjourned.
Okay. Good evening. Today is March 26th, and it is 7:20. As a quorum of the board is in attendance, I'd like to call to order the meeting of the Central Health Board of Managers. So managers, we do not have any public comment, so we'll proceed to the consent agenda. Could I have a motion for adoption of the consent agenda? So moved by Manager May, seconded by Manager Valadez. All in favor? Aye. Okay. We will now proceed to the regular agenda. Members, we're going to take this up slightly out of order. And I was actually looking for Monica, if she's around, because what I'd like to do is make sure that we take up pretty soon. Hi, Monica. I was wondering, I wanted to take out of order a bit so that we could be sure and addressed item number 6 while we're all here. Is that okay? Monica, is that okay?
Is 6 the
Ascension.
Yeah, absolutely. I was just making sure we got our outside.
Okay, so managers, we're gonna do that first, just so that everyone can be here for that. And so I'm gonna move us immediately into closed session. Let's see, I'll read items 1 and 4 through 7. I don't think we have all of them that we'll have to take up, but I'll read them. Item number 1 is receive a briefing on ACC and Central Health Partnership opportunities. Item number 4 is receive an update from council and discuss the impact of certain state and federal policies. Item number 5 is the Mazars item. Item number 6 is the Ascension item. Item number 7 is the Birch item. So, I announce that the board is convening in closed session to discuss agenda item 1 under Texas Government Code section 551.072, real property, and section 551.085, governing board of certain providers of healthcare services, and agenda items 4, 5, 6, and 7 under Texas Government Code section 551.071, consultation with attorneys. So we are going to go into closed session right now. Entering open session. Managers, we have 2 items remaining. One that's pretty important for us, and that's the compliance update, and then a brief update, CEO update. So we will begin with number 1, which is receive a briefing. No, I'm sorry. We will begin with number 2, receive and discuss a quarterly compliance report. So.
Thank you so much, Chair Kitchen and managers, and I'm very excited to introduce Andy Buell and Natalia Stankus, who are part of the illustrious Central Health Compliance Department. And this is the first of what are going to become quarterly compliance report outs from the compliance team to the board. This one is all an open session because Natalia and Andy are going to just describe what's going to be included in the board and gather feedback from you. In the future, they're likely to be closed session discussions, but really excited to have Andy.
Welcome and thank you for your patience with us and getting to this at 8:15. So.
Of course. Thank you so much for allowing us to take a seat. Like Monica said, we really want to share some of our expectations that we want to let you have for us. there should be a slide, there it is. That's
Okay.
what I was looking for. Chris, do you have a clicker or do I just? You can just say next slide. Okay, fantastic, all right. All good. While they get that going, so like Monica said, our goal is to establish a cadence and a structure for you all. We anticipate certain topics would be quarterly, while others would be annually. And we'll go over some of those. We believe that this will enhance transparency, risk mitigation, and then it'll also help us adhere to regulations. So in compliance, there have been a lot of changes just in this year alone. We want to make sure that these changes are impactful, that they're not just done in vain, but they actually have an impact on the organization and essentially our community that we serve. We have recruited the services from the consulting group. They are called Coker Group. They specialize in healthcare compliance. They have already began working with us. We're really excited to have them on our side. They will help us evaluate what resources that our compliance department needs, especially as we continue to grow and reach more of our community folks. Also, we are taking into consideration the recommendations of the Mazars report. We know that there are some gaps that were identified, and so we want to build some functions that we can use to bridge those gaps. Next slide, y'all. Thank you. So the Office of the Inspector General, the OIG, they have set forth 7 elements of an effective compliance program. And these are 7 elements that we really want to include and incorporate in what we do. So, first off, we have the designation of a compliance officer. We are in the process of that. We have posted, and I'm sure that they will be reviewing applications soon. And you all get to be a part of that selection as well. We also will establish lines of communication. So right now we do have a hotline that is available for folks to leave anonymous reports of noncompliance, and then we also make sure that our team members know that they can reach out to us, email, phone call. We make sure that we are available to them. And we communicate that quite frequently. We also provide effective training to our team members. So at the onset of employment, we make sure that we provide compliance training, expectations for our team members, and then we also have annual compliance training. Now these are done so that it's not so much an overwhelming and just numbing for our team members. We roll these out in different phases so that it's smaller chunks to digest, and they're able to really retain it. These all have quizzes or what is it? Evaluations, yes, thank you. At the end of them to make sure that they actually were able to digest and understand the content of that. We also are working with the Coker Group to build a more robust auditing and monitoring program. We want to make sure that we are doing effective corporate and clinical audits. So they are working with us to get that off of the ground. Through collaborating with HR, we have been able to establish disciplinary standards. We have created these policies so that team members are aware of what disciplinary standards they will be held to in areas of noncompliance. And we also do administer the policy management system for our organization. Currently, all of our departments are utilizing this. So every policy and operating procedure, it comes through compliance to be vetted for the for publication in that policy management system. And then lastly, of course, making sure that we provide expeditious responses to areas of noncompliance. If there is a report, we make sure that we jump on that quickly and give it the attention that it deserves. Next slide. So the compliance plan, of course, this does align with the OIG's standards. We do have a draft compliance plan that is with the Coker Group. They will be reviewing that and offering any suggestions if they see any gaps or any areas that we need to change in that. Now, this compliance plan, it basically serves as the foundation of compliance. It sets the goals that we have for that year. Of course, this would be something that we anticipate revisiting annually because regulations change, standards change, and the organization's goals may change. Next slide, please. So, similar but different from the compliance plan is the compliance work plan. So this is more specific. It builds off of that compliance plan. However, it actually says the what, who, when, why. It will assign deadlines. It will assign staff members to specific tasks. We will outline the actual duties that we believe our department will be taking on for that year. And again, this is structured to change annually. Next slide, please. So what we would like to propose to you all is that we provide you with annual reports that includes the compliance plan and the compliance work plan. We want your feedback, your input, your opportunity to review that, make sure that what we have put forth in our goals actually aligns with the mission of Central Health and that you all are satisfied with that. Also, establishing our auditing and monitoring work plan. Again, annually, this will change. We will take on different departments, different areas to review and to audit, and we want to make sure that that is satisfactory to you all as well. Any risk assessment findings, we would also like to share that with you guys. This will be a report of any potential threats that we have identified and also include those accompanying mitigating strategies. Next slide. Now, quarterly, we want to make sure that you guys have more frequent updates on more specific areas. Some of those things include the reports of noncompliance. So again, these will be the reports that come in through the hotline or directly to compliance. This will also bleed into the privacy incidents that we get. These include any material or information that's confidential that was either accessed or unintentionally provided to someone that shouldn't have gotten it. We will also provide our investigation outcomes. Now this goes back to our reports and our privacy incidents. The investigation outcomes, or the investigations, we want to provide you with the source, where that information came from, what type of investigation it was, and then what we did to rectify that or conclude the investigation. Our compliance training, as I said, that it is rolled out in several different phases. We do have completion reports that we obtain, and we would like to make sure that you all are aware of that. Of course, our goal is 100%, so we will definitely steer our team members to getting that stuff completed so that we can provide you with a satisfactory result. And lastly, part of the quarterly report would be our auditing and monitoring findings. Again, those would be just the areas that we have actually finished the audits for that particular phase or quarter. Next slide. And so with that, I thank you for your consideration. We truly do look forward to meeting with you all on a more frequent basis and getting your feedback as we move forward.
All right, thank you very much. Does anyone, I'll start on this side of the room, see if anyone has any questions or comments that they want to share with y'all. I'll start with Manager Valadez.
I'd just like to know, do I need to have this on now?
Yeah, I think, well,
We're in
yes.
public, open session, okay. I'm wondering whether or not we will be able to see in your annual report whether or not there were, first of all, what those non-compliant issues were as quickly as possible, because I haven't seen a compliance report that talks about our employees or our managers or anybody under Dr. Lee, because we don't see that. That goes to Dr. Lee, and he's our employee. And so with respect to this, I know what I've heard, as other people have heard some things, and I'd like to know whether or not they were resolved. And the only way to know that is for you to give us that report. And when would you expect to do that?
Sure. Again, in the quarterly report, that would be included, the reports of noncompliance and those investigations that were conducted.
I'm assuming it's gonna be things like, if you're gonna leave Central Health, you have, or you have evaluations, you have recommendations, you have things like that. So whether or not they happened, somebody left and they did not get an evaluation, or they did not, those kinds of things. So that's what I'd like to know.
Okay.
That's it.
Manager Brinson? Oh, she was gonna answer it, sorry. Thank you.
I was just going to recognize that doing a compliance interview when people are exiting the organization is an area where we have some opportunity and to get that implemented, and it is on our radar to do so. And we could certainly include that as part of the quarterly reporting, any significant findings from those.
I appreciate that, because I've heard those words for the last couple of years, and I'm still waiting. So thank you.
Okay.
Yeah, mine kind of segues into Manager Valadez. I guess, what depth of data we presented to us, kind of a macro view, or which is kind of, since Dr. Lee's our only employee, I mean, I can't imagine we'd have specifics presented to us, or.
Sure, yes, that would be macro.
Okay, thank you.
You're welcome.
Manager Montuan? Manager May? Just one quick question. I assume that you would be including things like, well, first off, it sounds to me like when you get it prepared, you'll share with us the plan, the compliance plan, as well as the work plan, right? Well, that'll probably answer a lot of our questions. I would just say that particularly as we go down the road and getting involved in Medicaid or Medicare, there's a lot of compliance and regulatory issues related to those programs. So I'm assuming that the scope of compliance includes that, right? Okay. As well as HIPAA. I mean, you have privacy, but there's also security issues around it.
Yes,
Okay.
absolutely.
Okay, so basically, in your plan, will you be enumerating the various, regulatory things that you have to show compliance with? So that we can see your compliance plan covers compliance with this, that, et cetera, law?
So the plan itself is pretty comprehensive. It doesn't really get into the specific line items that would be audited and things that would be looked at. It describes an overall approach to compliance for our entire department and how that would be structured. The work plan gets into more details on how that would be worked out. Okay. And then the actual details of what is going to be monitored and audited throughout the year and what raises up to that level of concern really is informed by the risk assessment. We should be doing an annual risk assessment that then helps to inform us on what is it we need to tune to be audited or monitored more frequently. And that certainly takes into account all of our regulatory obligations.
I'm just thinking, all I'm thinking is for a board level, we would just want to make sure we understood the scope of what was being looked at. Not all the details about when you're doing it and all that kind of stuff, but the scope, so that we understand when we're seeing reporting that we know the scope, because, you know, our responsibility as a board just has to do with monitoring compliance with regulations and stuff. And so we just need to know the scope of what you're looking at.
And that's really where the annual reports would come in, to see the plan for the year generally. That would address what you're talking about, your concerns.
Okay, thank you very much.
You bet, thanks.
Thank you all.
Okay, all right, managers, we're gonna move on to our last item now, which is receive and discuss a report from the president and CEO. This is the report structure that Dr. Lee has developed for us. And since he is out now, we have a couple of folks that are gonna give us this and they're gonna do it in 15 minutes, right? Okay, less. Okay, go for it. Okay, go for it.
All right, good evening again. Prior to 2022, any of our patients that had end-stage renal disease, their only method for dialysis was compassionate dialysis. So showed up in the ED when they were end stage or when they had system failure. Since 2022, we've enrolled 134 individuals into our dialysis program. Whenever we look at opportunities to improve healthcare, we look at, number one, the opportunity for the healthcare itself, and then the opportunity to improve quality of life. For patients enrolled in 2024, we had 54 individuals who were enrolled in our dialysis program. Our teams conducted multiple surveys. For those folks, 95% of them shared that they had an improved quality of life. In addition, our data and analytics teams looked 6 months prior to admission to the program and then since admission to the program, and found that there was a 95.6 reduction in ED utilization and hospital admissions specific to renal concerns. There was a study done in 2015 at Parkland that was cited in JAMA in 2018. And what they looked at is the cost for the avoidance of that hospital utilization, and found out that it was something like $5,400 per patient per month. And this was based on Medicare reimbursement. And so what our team did is extrapolate the months, the cost per month for our patients of cost avoidance utilizing that 2015 Medicare cost savings. And for those 54 patients alone, to date, it's $1.9 million saved. And again, those were Medicare costs in 2015, right? Not looking at 134 patients, not looking at current costs. So improved quality of life, we're saving dollars for the system. I hand it off.
Hi, everybody. Ted Burton, Chief Communications Officer. I'm really going to touch on the outside-inside section of the report, but I'm only going to hit on 2 items. There's many more in your backup. First, I wanted to talk about our measles campaign. Similar to the COVID pandemic, we've been working closely with Austin Public Health and Community Care to develop a measles campaign. Now you can see the slide. This is the campaign that we came up with. We created it in Spanish first, and then transcreated it in English with our advertising vendor Census. The campaign is launching now. It'll be seen on various platforms, including advertising on radio, online, paid social media, minority newspapers. We've been doing interviews. I have not been doing interviews, but Dr. Rodriguez with Community Care did an interview today with Telemundo and has more scheduled for next week. Primarily, we're focusing those interviews on promoting vaccine clinics that Community Care is hosting. They've hosted one so far. The next one is next Saturday, a week from this Saturday. They have launched a new landing page and a scheduling tool so people can go online and schedule those appointments. Everybody is eligible, based on some limited criteria that you can find on the landing page at Community Care. Addition to that, we have sent out 40,000 text messages to MAP and MAP Basic members about measles prevention, and the importance of getting vaccines. Happy to answer any questions.
Actually, can I add to the
Please.
measles? So this is an example of true collaboration between us, Community Care, and APH. Community Care has made themselves available for individuals who need to be vaccinated. When we were speaking with Desmar and APH, she shared with us that they were short about 500 individuals a month as far as meeting the capacity to vaccinate, which is why the Community Care then opened their doors. In addition, John, Christy from Community Care and other team members have been working with HEB in order to create kind of a contractual methodology whereby if somebody can't get into the clinic, but they're close to an HEB, they can have their MMR shot as well. And so, anything that we can do, to move away from these unvaccinated folks.
And we are, the last free clinic was at North Central, and the one next week from Saturday is at Southeast Health and Wellness Center, and we're pushing that out every way possible. Moving on to community engagement, we hosted our first community conversation on March 5th. Some of you attended. We had 100 RSVPs and 40 non-Central Health employees attended. We have several more scheduled in the future. You can see what the main topics were that the community wanted to discuss in the backup materials. We have another one scheduled on April 3rd, which is next week at the Del Valley ISD Administration Building. Another one on May 7th at Precinct 3. It's the Danny G. Macbeth Recreation Center. And then just note that the June community conversation may change. This is in Precinct 1 in Manor. We've worked closely with some of our constituents there, including Manor ISD and the City of Manor, and they've had some recommendations perhaps for a different location and date. So please just bear with us as we nail that down. And one last reminder, we're hosting these in the precincts of our Travis County Commissioners, and they are helping us promote and hopefully drive attendance to the community conversations. Sure.
Sure. Just really quick, are you guys collaborating with each of those? I know you have an agenda as you proceed with these engagement activities, but are you collaborating with commissioners, the individual commissioners in those precincts to learn what their needs are?
We are. In fact, they've all asked for us to focus specifically on the needs of their precincts. So chronic conditions, service expansions, and so we pre-meet with them and review the agenda as we did with Commissioner Shea, just to make sure we're covering what they would like us to cover.
And then they speak at it.
Yes.
What we're solving for, just a quick update on Foundation Communities and their Federal Navigator grant program. I think everybody here is aware that they were notified that the funding for that program would be reduced by 90 to 100%. The good news is they have received their current funding to date, and so there's no critical concern as of now.
Okay.
That said, come the next fiscal year, come September 1, there may be. So John and members of his team are working with Foundation Communities in order to determine what the appropriate budget is, and that'll come back to the board, and we'll share that information with you going forward.
Okay, thank you. Are you all done?
We're all done.
Thank
We
you
are
very
done.
much. Thank you. It's very, very helpful, and congratulations on all the good work you guys are doing. So, okay, members, we're now moving on to our last item, which is confirm the next regular board meeting date, time, and location, which is our next Central Health Board of Managers meeting is scheduled for Wednesday, April 23rd at 4 p.m. at Central Health Headquarters. At this time, I'm ready to accept a motion for adjournment. Manager Brinson, second Manager Valadez. All in favor? Aye. Okay. Thank you all.